Good morning everyone. Good afternoon students. Today we have a class on acute watery diarrhea and dehydration. It is an important topic, very important topic. So pay attention. If you have your Ghai textbook, you can open it. Open this topic in GI system and follow with me, because all presentation I have taken from your Ghai so that it is easy for you to understand and remember. Okay. Can we start? Okay, so what is definition of diarrhea? It is very important, definition of diarrhea. Pay attention, everybody be here. Stop every other activity. It is a very important class for your theory as well as your practical, as well as for your clinical skills and in use at your home in day-to-day activities. So what is diarrhea? First line, change in consistency and frequency of stools. Both words are very important, consistency and frequency of stools. Okay, so what will be the change in consistency? It will be liquid or watery stools. And what will be change in frequency? That is more than 3 times a day. Then you will label a child as having diarrhea. Now, next entity comes dysentery. What is dysentery? When your diarrhea is associated with blood in stools, if there is presence of any amount of blood in stools, then you will label it dysentery. So, clear the concept over here that diarrhea and dysentery are two different things. Diarrhea is change in consistency and frequency of stools, while dysentery is presence of blood in stools. I hope it is very simple. Now, third entity is persistent diarrhea. What is it? When acute diarrhea persists for more than 2 weeks, it is called as persistent diarrhea, more than 14 days. It starts acutely and then persists for more than 14 days. It occurs in 5 to 15% cases of acute diarrhea. It is different from chronic diarrhea. Chronic diarrhea starts insidiously, duration is more than 6 weeks, and it is not so much of watery type of diarrhea, persistent, and that occurs because of malabsorption syndrome. And this persistent diarrhea is generally because of infective pathologies. Moving on to next slide. Why we are discussing this topic, acute watery diarrhea? Now, it has burden on health of our children. There is huge burden of diarrhea. And what is the importance of taking up this topic? See, globally 5 billion cases per year occur of diarrhea in children and 2 million death occurs globally. In our country also, under 5 mortality in children, 20% is attributed because of diarrhea. That means if we are able to identify diarrhea earlier and also treat diarrhea earlier, then we will be able to reduce under 5 mortality by 20%, which is 1/5 of it. So it is a very huge chunk. Another importance of taking up this topic is, if the acute watery diarrhea is not dealt up properly, then it may lead to malnutrition and dehydration, which becomes an important cause of mortality, and both these makes a vicious cycle. So the child will become dehydrated, will become malnourished, again the nutrients will not be absorbed, so the cycle of malnutrition will go on and ultimately lead to mortality. So we have to deal aptly with cases of acute watery diarrhea. This is etiology of acute watery diarrhea. What are the causes? I have taken up this etiology chart from your Ghai itself so that you people can correlate it with your own book and remember it, understand it very well. See, causes of acute diarrhea, how you will enumerate? It will be bacterial, viral, parasitic. Simple to remember. Bacterial, you will have E. coli, and in E. coli, you will have, most common is E. coli, where you have enterotoxigenic, enteropathogenic, enteroinvasive, enterohemorrhagic, enteroaggregative types. Second bacteria, Shigella, very important, Shigella soni, flexneri, boidy and dysentery. Third important, Vibrio cholerae, where you get rice water stool diarrhea, lot of dehydration, sudden collapse, Vibrio cholerae, cholera, Salmonella. In Salmonella also you can have bacterial diarrhea, S. typhi and S. paratyphi ABC. Another is Campylobacter species. Bacterial segment I think is clear. Now we move on to viral segment. So when it is not bacterial diarrhea, then another major group is viral. In virus, the most important is rotavirus. Most common, 50% cases because of rotavirus. And mortality was very high because it was severe dehydrating gastroenteritis. But now we have vaccine for rotavirus. We are giving this vaccine to all our newborns, all our infants in our national immunization program, and dealing very well with this etiology of diarrhea and reducing the cases to 50%. Another viruses are human calciviruses, norovirus, sapovirus, enteric adenovirus serotype 4041. Other are estrovirus, coronavirus, cytomegalovirus and picornavirus. Then there are parasitic. Next major groups comes parasitic infections, where you have giardiasis by Giardia lamblia, you have Cryptosporidium parvum, Entamoeba histolytica, Cyclospora cyatinensis and Isospora belli. Okay, so in E. coli group, few cause dysentery also, like enterohemorrhagic and enteroinvasive varieties, and few cause acute watery diarrhea. You have to remember this chart. Please remember this chart. Take out this chart, stick in your book and remember. Now, next slide says, what are the risk factors or what are the groups which are more vulnerable to develop this acute watery diarrhea and its severe complications? So, these groups are younger age group, that is infants less than 2 years of age, malnourished children, those who already have malnutrition, they become prey of infections more readily. Then when there is low rate of breastfeeding and low rate of immunization practices, there this diarrhea occurs very high. We know breastfeeding prevents from diarrhea, and also in immunization now we have rotavirus and also other vaccines which prevent us from pneumonia and other septicemia, so that also we don't have diarrhea as a consequence of systemic infections. Next group to understand is achlorhydria or hypochlorhydria. What it means, that is hydrochloride HCl in our stomach is a preventive barrier. It damages most of the bacteria in the stomach itself and they don't reach the small intestine to cause diarrhea. Like Salmonella, most of the load is decreased in the stomach itself by the acidic pH of the stomach. But if the acidic pH is disturbed by any method, then we have more cases of diarrhea. H. pylori infection in the stomach also causes more diarrhea, or prolonged use of PPI. If you are using pantoprazole or omeprazole over a long period of time on and off, then you may have decreased acidity of the stomach and there may be recurrent diarrhea cases. Make it a point, note it, that this may be a cause of recurrent diarrhea in adults also. Now, important for is how is assessment of child with acute diarrhea, how we will assess. This is very important in your clinical practice as well as your case presentation, as well as in practical scenarios. If you join some hospital or if you are treating somewhere, being an mbbs, you are posted to your rural facility somewhere and there you get a case of child having diarrhea, then how you will go forward with it. Now, first of all, you understand what are your goal of assessment in this child. Number one, determine type of diarrhea. As I told you, determine whether this is acute watery diarrhea, it has blood, so it is dysentery, or it has persisted for more than 14 days, so it is persistent diarrhea. So first label what is the type of diarrhea in your diagnosis. Now look for signs of dehydration and other complication if any present. Complications I will tell you in follow-up slides what may be the complications you have to check for when you are checking a child. And signs of dehydration we will discuss in details because that is a major question for MBBS students. Then assess malnutrition. Whether you are dealing with a malnourished child, you know the criteria of severe acute malnutrition. You have read 3 criteria, that is weight for height less than -3 standard deviation, bipedal edema plus mid upper arm circumference less than 11.5 centimeter. So just label that this child is with severe acute malnutrition, with SAM or without SAM. Then move to rule out systemic illness. Look for any other systemic illness, cardiac disease, respiratory disease, septicemia, UTI, tuberculosis, skin infections, any other disease this child is having along with diarrhea. Then assess what was a very important feeding. Never forget feeding or nutrition in pediatric age group. Okay, so look for what was the feeding pre-illness. बीमारी के पहले बच्चा क्या क्या खा लेता था, क्या क्या खाता था, एंड ड्यूरिंग इलनेस, और बीमार होने के बाद उसकी एपिटाइट कितनी कम हो गई है, अब वो क्या खा पाता है और क्या नहीं खा पाता है, या फिर पेरेंट्स ने उसको कुछ खाना देना बंद कर दिया है, या फिर किसी ने उनको एडवाइस कर दिया है कि डायरिया में खाना नहीं खिलाते हैं या पर्टिकुलर डाइट नहीं खिलाते हैं, तो क्या ऐसे कोई चेंजेस उन्होंने किए हैं. यू हैव टू मेक अ नोट ऑफ दिस, व्हाट वाज द फीडिंग प्री इलनेस एंड व्हाट इज द फीडिंग ड्यूरिंग इलनेस. ब्रेस्ट फीडिंग बच्चे का ब्रेस्ट मिल्क तो नहीं बंद कर दिया है, सेमी सॉलिड खाने वाले का सेमी सॉलिड चल रहा है कि नहीं चल रहा है. डाइट इज वेरी इंपॉर्टेंट इफ यू वांट टू ट्रीट डायरिया. भूखे पेट डायरिया ठीक नहीं होगा. यू नीड फूड इन द इंटेस्टाइन. Now, when you know what are your goals, what is your goal of assessment, what you are trying to assess, let's move on to how you will ask history. What are the points of history taking? You will ask, how was the onset of diarrhea? It started acutely, abruptly, or it is insidious. अभी अचानक से इसको लूज स्टूल होने लगे या बहुत लंबे टाइम तक धीरे धीरे ऐसे ज्यादा मोशन ये करता ही रहता है. दैट इज मीन्स acute डायरिया या फिर persistent डायरिया या फिर chronic डायरिया. ओके. ड्यूरेशन एंड नंबर ऑफ स्टूल पर डे. नाउ यू एस्टेब्लिश कितने स्टूल दिन में जाता है और कितने दिन से जा रहा है. दैट मीन्स मोर देन 14 डेज हो गए हैं तो यू लेबल इट परसिस्टेंट डायरिया, और अभी नंबर ऑफ स्टूल मोर देन 3 अगर हो गए हैं, वाटरी स्टूल मोर देन 3 हैं, तो यू विल लेबल इट डायरिया. देन आस्क फॉर ब्लड इन स्टूल्स. क्या वहां पे ब्लड है स्टूल्स में? देन इट इज यू विल लेबल एट डिसेंट्री. वॉमिटिंग इज एसोसिएटेड. इट इज प्राइमरीली मे बी वॉमिटिंग प्रीडोमिनेंट लाइक रोटावायरस, जहां वॉमिटिंग पहले बहुत ज्यादा होती है, उसके बाद डायरिया होना स्टार्ट होता है. सो वॉमिटिंग प्रीडोमिनेंट. ओके. देन आस्क फॉर अदर सिम्टम्स. इज इट एसोसिएटेड विद फीवर विच कैन बी बिकॉज ऑफ सेप्टिसीमिया इन द बॉडी, यूटीआई इन द बॉडी, निमोनिया इन द बॉडी, और एनी अदर फोकस ऑफ इन्फेक्शन. कैन बी मलेरिया, कैन बी ट्यूबरकुलोसिस. कॉफ. इफ कॉफ इज देयर देन रेस्पिरेटरी सिस्टम निमोनिया के साथ डायरिया में बी एसोसिएटेड. सीजर्स, दैट इज द child is having convulsions. It may be because of some viral encephalitis associated with diarrhea, viral illness, or it may be a complication of diarrhea, that is electrolyte imbalance. There may be meningitis, encephalitis associated. So it can be a cause per se, or it can be complication of diarrhea. Electrolyte imbalance, dehydration, hyponatremia, all these can cause seizures, acid base imbalances. Then you have to ask for history of measles. Although nowadays we are not seeing much of cases of measles, thanks to MMR and MR vaccine which we are giving to all our children at 9 month and 15 month of age. Otherwise measles is a detrimental disease. It leads to, it decreases the immunity and leads to prolonged cases of diarrhea over months. So ask for history of measles. Measles leads to diarrhea, malnutrition, everything. So and increases the morbidity and mortality in childhood age group. Then you ask, as we discussed, food history. Never miss food history in any child ever. Always ask what was the food history pre-illness and what it is now. Okay. Then ask for another important group, that is, has the child taken any anti-motility drugs? Because in the periphery, in the quacks, in small centers where people don't have idea how to deal with pediatric age group, they usually provide opioids and loperamide like drugs which decrease intestinal motility, and these drugs becomes detrimental for children because it leads to stasis of the bacteria in the intestine. It is not washed off. It leads to more toxic effect and it causes abdominal distension and paralytic ileus also. Then immunization history, which is also very important. You want to establish that whether your child is immunized against rotavirus or not. Examination. After history taking, you know what you have to do? Physical examination. In physical examination, you will do general examination, head to toe examination as we teach you in your clinical classes, and then you will do systemic examination, that is abdomen per se. So in physical examination, points which are you have to focus here, learn them by heart, try to make a picture, imagine these points, that what you have to do, you have to assess degree of dehydration. डायरिया वाला बच्चा है, अब हम देखना चाह रहे हैं कि डिहाइड्रेशन जानलेवा हो सकता है, पानी की कमी जानलेवा होती है, कहीं इस हमारे बच्चे को हो तो नहीं गई है. तो डिग्री ऑफ डिहाइड्रेशन असेसमेंट, उसके लिए कुछ पॉइंट्स हैं. वी हैव फ्यू पॉइंट्स. वी हैव अ टेबल मेड इन घई, दैट आल्सो आई विल शो यू. So in general condition, you have to look for the general condition. Then you will look at eyes, you will look for tears, you will look for mouth and oral mucosa, then thirst, then skin turgor, and then you will decide and treat. So head to toe you will see what is the general condition, whether alert, irritable or lethargic. Then eyes you will see, in eyes how is the eyes, sunken eyes, normal eyes. Then in tears, tear present, tear not present. In mouth and oral mucosa you will take your finger, take inside of the lateral of the mouth, inside of your cheek, and look for whether the oral mucosa is moist or it is dry. Then you will look for thirst, whether the child is not thirsty or it is very thirsty, drinking very eagerly, or the child is not able to drink. Then you have skin turgor. I will show you by a picture with these index finger and thumb at the abdomen. On the side of the umbilicus, you have to just pick a skin pinch and then leave it and see whether the skin going promptly back, skin going slowly back. If the skin taking 2 seconds to go back, then it is a sign of severe dehydration. Okay, not going back. So it will promptly go back, slowly going back, or will not go back like that. Pinch will remain there itself. So skin turgor is delayed when there is dehydration. Then we will decide what type of dehydration, that is no dehydration, some dehydration or severe dehydration. Then we will treat according to plan A, plan B or plan C. Decide and treat. Degree of dehydration, what you have to decide and what you have to treat. So decide on degree of dehydration, that is no, some or severe. When there is no dehydration, the fluid loss assessment is less than 50 ml per kg. Some dehydration it is 50 to 100 ml per kg, and severe dehydration is more than 100 ml per kg. We have like lost. Diseases of, now see, this is the chart which is given in your ghai. Deliberately I have taken this from your ghai so that you people can understand it, relate with it and by heart it. Assessment of dehydration in patient with diarrhea. This will come as a long question in your exams and you should be thorough with it. Easy to, you should, everyone, all 100% of you should by heart this chart. What you have to do, you have to look at condition. How is the condition? He is well alert, restless, irritable, lethargic, unconscious, floppy. 3 conditions are there. Label it. What is the condition? Number 2, eyes. Normal, sunken, very sunken and dry. Label. Number 3, tear. Tears present, absent. Mouth and tongue. Moist, dry, very dry. Thirst. Drinks normally, not thirsty. Thirsty, drinks eagerly. Drinks poorly, is not able to drink. These are the 3 conditions. We are moving from no dehydration to some dehydration to severe dehydration. And see, in no dehydration, your child is well, alert, normal, present, moist mucosa, drinks normally. But in some dehydration, he has become restless, irritable, sunken, absent tears, dry mucosa, drinking eagerly. This is the phase where you have to intervene and don't allow any child to move to severe dehydration. In severe dehydration, the child becomes lethargy, floppy, unconscious, sunken eyes, absent tears, very dry oral mucosa and is not able to drink properly. You become vulnerable. Then after look at, you have a condition feel. Now you have to use your hands and you have to feel the skin. So feel the skin pinch or along the side of umbilicus on the abdomen. Make a skin pinch and see, goes back quickly. It is no dehydration. Goes back slowly. It is some dehydration and goes back very slowly. It takes 2 seconds, more than 2 seconds. So it is severe dehydration. Now decide in the first category the patient has no signs of dehydration, so it will be caused as no dehydration and you will use the treatment plan A. In the second case, if the patient has 2 or more signs from the above, then it is some dehydration. Only 2 signs is enough. If you have any 2, it is some dehydration. Weigh the patient and start treatment according to plan B. And in third category, if the patient has any 2 signs or more, this is severe dehydration. Take the patient immediately into account, admit the patient, start treatment immediately, weigh the patient and start plan C urgently. See the word urgently, very urgently. Here you have to act urgently. It's an urgency. Few points which are written below the table. A lethargic child is not simply asleep. एक बच्चा सुस्त है तो ये मत सोचिए कि वो बच्चा सो रहा है. A lethargic child is not simply asleep. The child cannot be fully awakened, has a dull mental state, and the child may appear to be drifting into unconsciousness. In some infants and children, eyes normally appear somewhat sunken. किसी किसी बच्चे की अपने आप ही संकन दिखती है, तो आप कैसे कंफर्म करोगे कि डिहाइड्रेशन से है कि नॉर्मली है? आस्क द मदर. मम्मी से पूछो कि इसकी आंखें ऐसी ही रहती हैं कि अभी अभी ऐसी हो गई हैं, तो वो आपको बता देगी. ड्राइनेस ऑफ द माउथ और टंग जब आप देख रहे हो, पैल्पेट विद अ क्लीन फिंगर. माउथ में बी ड्राई, कोई बच्चे मुंह से सांस लेते हैं उनमें माउथ ड्राई भी हो सकता है और माउथ वेट भी हो सकता है जिनको रिसेंट वॉमिटिंग हुई है और उन्होंने ड्रिंकिंग करी है, तो ये इन कंडीशंस का भी ध्यान रखना है. स्किन पिंच जब हम देख रहे हैं तो इट इज लेस यूजफुल इन सीवियर एक्यूट मैलन्यूट्रिशन, क्योंकि जो मैरास्मिक चाइल्ड होता है ऑलरेडी उसकी स्किन श्रंकन रहती है तो आपको समझ नहीं आएगा. क्वाशियोरकर चाइल्ड की फॉल्सली इडिमेटस रहती है तो आपको समझ नहीं आएगा. तो दिस जो स्किन पिंच है इट इज नॉट यूजफुल इन केस ऑफ सीवियर एक्यूट मैलन्यूट्रिशन कैटेगरीज. चलो ये बाय हार्ट कर लेंगे सब लोग. Now, is there use of lab investigations when we are dealing with acute watery diarrhea? Not much of use. Answer is not much of use. Okay, we can treat it without lab investigations. Okay, there are few conditions in which stool microscopy is helpful. What are those 2 conditions? One is cholera, where you will look for darting movements of Vibrio cholerae when you make hanging drop preparation. And another is giardiasis, where you are going to look for trophozoites. Stool microscopy, 2 things will be helpful. If it is dysentery, then you can go for stool culture to look for whether blood is obviously visible in dysentery, but stool culture you are doing for antibiotic sensitivity pattern to look for culture and sensitivity of antibiotics. That's why you are doing it. What is the known organism, to know the organism behind it. Then what is the role of stool pH or reducing substances in the stool? This is useful when you have cases of secondary lactose intolerance which occurs in persistent diarrhea. These are 3 conditions where lab investigation is helpful. Otherwise, in acute watery diarrhea, you can manage it well without much of investigations. See, this is the picture of sunken eyes. I have written sunken eyes calling for help. So when there is sunken eyes, dehydration, diarrhea is there, and then sunken eyes appear, that means some dehydration has been established and they are calling for help. Immediately intervene, rehydrate them, provide them ORS, provide them fluids, provide them diet, nutrition and care. This is sunken eyes, this is normal eyes. You all can appreciate very well. Sunken eyes, normal eyes. We have related picture downwards. There is a child with severe dehydration become unconscious with sunken eyes. This is a picture of how you do skin pinch on the side of umbilicus, lateral part of the abdomen. You do a skin pinch with thumb and index finger. Complicated cases, or I would say that associated findings of diarrhea, then these cases becomes difficult to manage, okay, or they require more care. What are they? If a child is anemic, having a severe pallor, it is a malnourished case with diarrhea, labored breathing already present, it can be because of acid-base imbalance, acidosis because of diarrhea, loss of bicarbonate, or it can be because of pneumonia, associated infections, altered sensorium seizures, in a child can be because of meningitis, encephalitis, can be because of dyselectrolytemia, acid-base imbalances. So electrolytes is very, very important in dealing with diarrhea. Then another is abdominal distension and paralytic ileus. Abdominal distension, as we discussed, can be because of some opiate drugs taken, which decreases the motility of the intestine, loperamide and all, or it can be because of paralytic ileus, which is hypokalemia, because of loss of potassium. There is hypokalemia. So because of hypokalemia, the intestine is not working, bowel sounds are absent. In this case, we have to make the child NBM, nil by mouth. Also, we have to do nasogastric suction back, because we have to provide rest to the intestine till the bowel movements come back. Also, we have to give higher dose of potassiums. Orally possible, we cannot give orally. IV, we have to give high dose of potassium to treat paralytic ileus. Another complication, child is not passing urine, that is oliguria, which may lead to renal failure in severe cases.